Very good evening. Thank you very much, ladies and gentlemen. Thank you very much, Madam Chairman, for the good introduction. And my name is Muhammad Fadzila from Malaysia. And thank you very much for giving me the opportunity to stand here in front of all of you to give my opinion on this a special topic, especially on this community psychiatry. But I changed a little bit of this discussion because this is a psychopharmacology conference. So I will discuss a little bit on this, the needs of treatment in the community according to the psychopharmacologist's point of view. So I'm going to discuss with all of you case of difficult to treat a depressive disorder. All right, as mentioned by Dr. Abdul Qadir just now, a depressive disorder becoming a very interesting disease, and by 2020, depression will reach second place in disability adjusted life years, and it will become a main burden to most of the patients. And obviously, when we treat depressive disorder, right, we will discuss why patient is not improving with our regimes of treatment. Obviously, the textbook will always blame, check on your dosage, the duration of treatment, whether the patient is compliant or not, side effects, whether they have a relapse or other kind of problems. But we have to understand, by looking at this improvement after we have started the patients on antidepressants, that if our patient is not improving with first or second drugs, the opportunity or the chances for this patient to improve with the third drugs is less than 15%. You see that it is always on the reducing stage. And some of them will develop all kinds of other side effects, and some of them will left with residual symptoms, and some will left with cognitive impairment, such as the executive functioning, which is not functioning very well, and as well as the memory impairment. And I believe that earlier this morning, Brian Leonard and his colleague had discussed all this, the novel mechanism of antidepressant. I'm not going to repeat that again. And along this presentation, I will show you, about this beautiful picture, on this, how we divide these depressions according to the physical symptoms, the core symptoms of the depression or emotional symptom, as well as the, what we call this, the cognitive impairments. And I like this picture because this is a classical picture. I got this a long time ago, and it's still hanging on my wall in my room. And I believe that this morning they have discussed about this, how the symptoms comes around. Basically, we are still stuck with all this dopamine, noradrenaline, and serotonin model, the monoamine model. And of course, I believe that many psychopharmacologists earlier this morning or previous for the past 2 days had discussed about this. I'm not going to touch this again. And when we started we have decided our patient to put them on antidepressant, right? We always promise our patients that we are going to reduce your symptoms or remove the symptoms. We will minimize the risk or the relapse. We destroy your functions. But at the end of the day, what we want to offer to our patient is that he or she should achieve a remission, right? And we have to understand that residual symptoms only will lead to a recurrence. Let me share with you one case that had been referred to me earlier of last month. Yeah, this patient is a 36-year-old lady, was referred to me because of uncontrolled depression after she was started on antidepressant for the past about a year, I think 9 months to 12 months. She was started earlier with SSRI, then after that someone not happy with the SSRI, patient complaining that the patient is not improving. Someone changed this patient back to TCA. Mind you that in my country, some people still using a tricyclic antidepressant, but it is a dinosaur to me. Not many people using that anymore. And after a few months on TCA, patient still not improving, and back to SSRI. Then after that, a combination of SSRI and TCA. Then after that, I realized that this patient was put on SSRI and carbamazepine. So you see, many psychiatrists believe that this drug works, but I will ask you one question. Before you prescribe your medicine, is there any evidence that this drug works? What kind of criteria for you to start this medicine? And if someone challenge your decisions to put this patient on SSRI and carbamazepine, do you think that you can stand and say that I have the scientific reason that this drug works? So this is the question that I'm going to discuss with you this evening. All right, back to this. Zimmerman in 2006 already predicted, right, what kind of patients that will improve with medications, all right, or what kind of depressed patient will improve. Number one, he predicted, or he found out from this study, that patient who has this positive mental health, right, such as someone who is very optimistic, with a self-confidence, someone with an urge or tendency to return to his or her usual and normal self, return to usual or level of functioning, and these are the three most important to determine whether the patient is going to improve or not. If you see that this patient is not having these three criteria, then according to this Zimmerman's finding, your patient is not likely to have a full remission. And obviously that improvement also talk about a better quality of life, and you should have a less psychosocial impairment. And when we talk about this recovery, people say, well, remission, all right, improvement, not improving, partial improvement. Where is our guidelines? So what are the things that we need to describe to our patient that you are improved? So I would like to share with you this very important paper that published in Psychological Medicine in year 2007, the concept of recovery in major depressive disorder. That we only can say that the patient is recovered if, right, this is according to the FAVA, that the patients remain in full remissions despite discontinuation of treatment, whether pharmacological or psychological. Number two, if subclinical or subsyndromal symptoms are present, they do not interfere with everyday life and social adjustment to a considerable degree. Number three, the patient reports psychological well-being in at least one of the 6 areas. These are the areas that uh, according to the RIF model, we should be able to control our environment, we should be able to control our personal growth, and we should be able to control our purpose in life, right? There is the subject has goals in life and sense of directedness, feels there is a meaning to be present in this world, and then so on, right? And then you have the autonomy in life, the self-acceptance, positive relation with others. So then the last one, unfortunately, is not occurring in our psychiatric fraternity. There is, we can measure before and after, like we measure the blood level of something. This is something which is away from psychiatry at the moment. And this is another very important Nuremberg paper that published in 2010 in Psychological Medicine on this STAR-D project. Yeah? There is the residual symptoms after remissions of major depressive disorder. So, he found out that according to this scale, there is whether the patient is presented to you with fatigue, low mood, impaired concentrations, and if according to the QIDS, insomnia is one of the most important residual symptoms that you need to entertain, low mood and impaired concentrations. And another study here by Zimmerman this is a very new study. I got this, I think from this comprehensive psychiatry. Last month, the Rhode Island study, Zimmerman looked at these residual symptoms in patients who are presumably in remissions. We always assume that our patient improve with treatment. And he used this HAM-D17 on 274 major depressive disorder using this clinically useful depression outcome scale, quick inventory of depressive symptomatology. And he measured this psychosocial functioning, QOL, and the result shows that a residual symptom actually is strongly related to psychosocial functioning and QOL. In other words, that if you treat your patients and your patient still presented with a residual symptoms, very likely that your patient is not having good psychosocial functions, and your patient also not having a good quality of life.
2 minutes more.
And high rate of residual symptoms in patients who are in remissions. Yeah? And impact of residual symptoms of major depressive disorder. For this Baker, follow up this patient for 10 years. And he looked at this psychosocial functioning on this effect on these residual symptoms, and he found out that the chances for this patient to have relapse, to have residual symptoms, to have a very bad social support, to have a very bad marital relationship, yeah, and also with express emotions. So you always can predict your quality of life and psychosocial functioning in your patient within 2 weeks of treatment. That is the 14 days. If your patient is not improving or did not show any good quality of life within these 14 days, very likely that your patient is not going to have a good quality of life later on. And he followed up this patient for 14 days, then after that 28 days, then so on. Then the result is very significant result. Yeah? And it also shows that residual symptoms is associated with a worse longitudinal marital and working history and worse performance. And of course, this effect will reduce the ability to function. They have a faster time to relapse. Yeah? If other patients, at least they have a 60% chances to relapse, but those with these residual symptoms, they have only 90% less than that. So, the conclusion is that these residual symptoms will have a strong predictors for recurrence. And of course, I'm not going to touch on this because of the time constraint. But what I want to share with you is that many people use many criteria to start on this antidepressant, right? And from this study, it shows that there is no what we call this substantial difference in efficacy of effectiveness, yeah, on this meta-analysis. Response and remission rates generally similar between SSRI and newer classes, right? And
Prof, can you make a summary, please?
Since I don't have enough time, yeah, so I will summarize that. Can you give me just a few minutes to summarize this? Yeah. So what I want to share with you, actually, the main thing I want to share is that when you prescribe your medicine, right, there must be a criteria for that, yeah, and we have many criteria. Some people use NICE criteria. In Malaysia, we have our own CPG, right? And what I'm very interested with this Canadian Network of Mood and Anxiety Treatment, the CANMAT criteria developed by Sidney Kennedy, Raymond Lam, and his colleague. Yeah. Usually, we don't have any problem at this level, right? People will start most of the time now. They start with evidence. Most of the time, start with SSRI antidepressant. But since later after that, then they have a problem to decide which drug to whether to switch or to add on, right? And what are the evidence you have for that? So I'm not going to discuss this in a detail, but of course there is advantages and disadvantages of the practice, all right? And I keep on telling my trainees, my doctors, yeah, that if you want to practice, at least there are a few things that you need to remember. The first line drugs, the second line drugs, and third line drugs. And you must know why they call it the first line, second line, and third line, right? You need to know the evidence. So according to this Canadian HTA program, yeah, so obviously that the first line is still switching, right, with the level 1 to level 2 of these drugs. And then for the adds-on, right, as the first line, right, so only with the second generation antipsychotic with lithium and this, right? You can get this from the Canadian. Then after that, the second line, whether it is adds-on, right, to switch, and all these other drugs which is being studied. And if you don't believe me, you always can go to the original paper and look the evidence for it. And usually we don't have problem here. Here we started to have problem here. We combine the pharmacological treatment as well as the psychological treatment. Then the problem started here when the patient still not improving. Then whether the patient is not is going to choose ECT, or you want to put this patient on ECT or other regimes of physical treatment, right? So for the patient that I mentioned to you just now, she refused ECT. So what choice do I have next, right? So, and of course, we have this transcranial magnetic resonance lab, right? I offered this to the patients. This patient started with, I think 40 plus HAM-D score. There is a very severe depression. And after after 12 course of this TMS, then this patient shows some improvement here, and obviously that all this the Australian paper showing that doing the inferiority study, and this paper concluded that RTMS is not inferior to ECT, all right, and it is safe and less invasive than the ECT, and they have a limited evidence that RTMS may be less effective than ECT, all right? And of course, this is the machine in our lab, and this is what we call this my technicians with this machine. And what I want to conclude here is that, number one, you can predict whether your patient is improving or not. Number two, that when you practice, you need to have evidence every time you sign up the patients on any antidepressants, right? Then, number three, the residual factor is very important. I always think that, according to the definition, they say that it is a residual symptom of depression which is not enough to make a diagnosis. It is not an entity on its own. But I always think whether this residual depression is a dysthymia, right? And can we challenge the concept of dysthymia with this concept of residual depression? So with that, I thank you for listening, and if you have any questions, you can always ask me here or after this. And if you still need evidence for any of my part of my presentations, you always can write to my email, and I always can post to you all the evidence for my presentation, all the original papers for that. All right, thank you very much for listening.